final talk for this evening comes to us from Dr. Thomas McIntyre. He is affiliated with both SUNY Downstate Medical Center and Kings County Hospital, and is the director of the Center for Global Surgery and Public Health. So, Dr. McIntyre.
Hello, how are y'all doing?
Great.
Good. Thanks for staying. This is the last talk, so I hope you guys can stay awake. So I'm a surgeon at Kings County Hospital. You've heard from some other people from Kings County, and I'm going to talk about surgery today, particularly surgery in the developing world. And getting ready for this, I have to admit I watched a lot of Tedmed talks to see what's going on, and I think undoubtedly we have the most unique Tedmed space I've ever seen.
We got a tower up here. I don't know what that is. It's like a boat thing.
But this is very cool. Anyway, so I watched a lot of videos, and particularly I watched a lot of surgical videos, and I have to admit I started getting a little nervous because most of the surgical videos were about gadgets and pumps and simulators and all this really cool technological kind of stuff. But my talk is really going to focus on things that can be done in this room right up here, which really is not that fancy. This is a typical operating room you can find in countries throughout the world. And what I'm going to talk about is a huge problem that can actually mostly be taken care of in this operating room. And, sorry, come on, slides. The problem I'm talking about is global surgical inequity, and it's a big problem. And one of the things I hope to convince you guys of today is that it is in fact a problem. So let's just go through some basic stats. There are 230 million surgeries done every year in the world. However, only 3.5% are done in low-income countries. And you know, where are low-income countries? They're where most of you guys would think they are. Sub-Saharan Africa, Southeast Asia, a little bit of the Caribbean, particularly a country we know as Haiti, and some countries in Latin America. Okay? So, surgery is rare in these countries. You gotta understand that surgery is rare. Okay? How many people in this room have had surgery? Raise your hand. And I bet you it's even more than you guys think. What do you think the average number of surgeries an American has in their lifetime is? 3, 4, 5? 1? That's actually 7. All right? You may be forgetting about C-sections, circumcisions, wisdom teeth, all this stuff. Okay? Hey, it counts. All right? That is surgery. Okay? So, not a lot of surgeries going on in these countries. And what are the consequences? Who cares? So you don't have surgery. What happens? I'll tell you what happens. First of all, pregnant women die. Okay? Women in the prime of their life, young women about to give birth, die. And how many women die? A lot. In 2011, over 273,000 died. 775 a day. Okay? The sad thing is that 90% of these are preventable. All right? An even sadder thing is that 99% are in developing countries. Okay? Almost all of them are in developing countries. Who here has known someone that has died in childbirth? Not one person raised their hand. I guarantee you, if you were in a room in Burundi with 100 people, everyone would raise their hand. Because I was there a month ago and I did the same thing. Everyone raised their hand. What else happens? There is excessive morbidity and mortality from injuries, okay? 2002, it's about 10 years ago, but still, 1 million deaths from road traffic accidents. 20 to 50 million disabled. And that number is just going to get worse, because roads are getting better, cars are getting faster, the developing world is blowing up, and road traffic injuries are just going to become a major, major problem. Okay? What else happens is that natural disasters and mortality of them are increasingly amplified because there's no access to care. We saw that very, very obviously in Haiti. This is Haiti, you know. 200,000 people died in Haiti from a lot of different reasons, but one of the main reasons was lack of access to surgery. We just saw it in Boston. 3 people died in this bombing, right? If you were in Haiti, it probably would have been something like 40, right? Because a lot of those people went to the hospital and got surgery and had their life saved. Okay? What are the other consequences? Delayed surgical care, not getting surgery on time, or getting substandard surgery causes a lot of problems. Things like obstetric fistula. Who knows what obstetric fistula is? Most of you people do, some don't. But it's when basically you have stool coming out of your vagina because you had an obstructed labor and you weren't able to have a C-section. And that is a horrible problem to have. And 3 million people across the world have that. What else do people have? Delayed fractures, burn contractures, and what ends up happening is this deforms people for life. Okay, this is a young child whose life will never be the same. What are the other consequences? Surgical pathologies, regular old things become lethal, deadly. This is a guy with a massive hernia, and he could very well die from this. Let's do another poll. How many people in this room have known people that have died from a hernia? Okay, no one. Again, I guarantee you go to Burundi, ask the same question, everyone raise their hand. Because I did it about a month in December. Okay? So there's a big problem, right? Is it a public health problem? Is this a public health problem? What do you guys think? All right, most people say yes. But the reality is, this is a pie chart of a breakdown of all the academic papers relating to public health for some year in the mid-2000s. And basically, none of these topics are surgical. So pretty much all communicable diseases, family medicine, preventive medicine, things like that. So it's traditionally not in the paradigm of public health. Okay? I think that yes, it is. It is a public health problem. And what I think is that, and what a lot of people in the surgical community are beginning to realize, is that surgery is actually a pillar of community public health. And the vision is that essential and emergency surgery, the things we were talking about, should be available to the public at all times. Okay? And then the final thing is that global health, what we know as global health, should not be a competitive battle for resources. Okay? It needs to be a coordinated movement that includes everything. Just like the last speaker said, it's not way, it's ways. There are many different ways to ensure communal, comprehensive public health. So what's the strategy? How are we actually going to do this? And it's interventions on basically 4 major kind of axes. The first is timely intervention to prevent maternal mortality. Okay? It's pretty basic. This is a C-section. This saves the mom's life and saves the baby's life. Okay? What else can we do? We can treat injuries. We can get people triaged and treated, particularly orthopedic fractures and injuries. This is a young kid in Mozambique who's got a nice cast on. Probably won't have problems walking or deformity now because of that. What else can we do? We can do basic surgeries on things like cataracts and hernias that improve people's quality of life and improve people's productivity. Even things as simple as basic dental surgery makes a big difference in people's quality of life. Okay? One of the final strategies is to try and intervene in emergent and non-emergent abdominal conditions. And this is a young boy who fell out of a palm tree, who eviscerated his intestines. We put him back in and packed his wound, and he did fine. Okay? So, the problem is that surgery is complicated. And I believe the title of this talk is, what is the next great challenge to public health? And it's my feeling that it's actually surgery. And it's not because the surgical problem is bigger than the malaria problem or the HIV problem, or that it's more important than the malaria problem or the HIV. It's because it's more complicated to actually perform, all right? And why is that? You got to build infrastructure, you got to train people, you got to have a supply chain, you got to maintain equipment, you got to have modern surgical techniques continually being updated, and this stuff all costs money, so you got to make it affordable, and then you got to maintain that. So it's an order of magnitude and difficulty of interventions that the public health community has not tackled something this massive. And that's why I think it's the next great challenge. So, we have to be able to provide anesthesia. We have to be able to fix things like this operating room table. And we got to be able to train people, okay? And we have to be able to train people locally. 5 minutes, you got it. And in order to accomplish this, we got to really pull out all the stops. Use whatever cliches you think about. Think outside of the box. Pull out the stops, like I said, and you got to use all your basic tools to try and accomplish this goal. And one of the things is things crazy like this: laparoscopy in Mongolia. Is that a good idea? Is that a good use of resources? And that's a legitimate, controversial question. Okay, this is a nice year in Mongolia. And we actually started a program in Mongolia, and these people are not Mongolian, but this is a typical family in the developing world, large number of kids, few parents. And I was at a conference several years ago, and one of my buddies, Paul Simonson, says, man, it's much more important for a poor person to have laparoscopic surgery than a rich person. And I was like, what are you talking about? And then I thought about it after a while, and I'm like, gosh, you're right. Why is that? I know some of you guys have seen this slide before. What's that? They're going to be back to work early. They're going to be back to take care of their kids early. They're going to be back to farming, livestock, whatever they have to do early. They don't have post-operative complications, wound infections. So the bang that you get out of something like laparoscopic surgery is amplified. Much greater when you do it in a poor community, in a resource-poor setting. Okay? What are the other benefits? And this is actually really interesting. I don't know if you guys can see this, but this is a slide that shows what happened in Mongolia after we started doing laparoscopic cholecystectomies. So we did laparoscopic cholecystectomies, that's cool. But the really cool thing is that all cholecystectomies went up. And the reason why is because people started going to the hospital and having these amazing minimally invasive experiences, and the community became more confident in the healthcare system. So things with technological advances can in many ways and situations help push care and help push confidence in Western medicine. So the reason why I bring this up is not just because it helps push Western medicine, but also it's what most surgeons across the world want to be. This is a poll from the West African College of Surgeons, and it basically asks them what they want to learn. And they want to learn laparoscopic surgery. They want to learn endoscopic surgery. They basically want to learn modern surgery, the most advanced techniques, because they want to be able to do the best thing for the patients possible. And what we want to do is help facilitate it. Okay? And that's the only way we're going to combat things like this. This is a crude slide, but it basically represents what's going on in the world in terms of brain drain, in terms of academic and clinical professionals leaving resource-poor countries and going to resource-rich countries where there's not as much burden of surgical disease. Okay? So I hope that gave you an example of ways you kind of have to think about the situation differently. You have to be able to adapt to each situation and pull out all the stops. One of the other things that's done in Africa are things called surgically trained providers. And what that is are these guys here. They're actually not doctors, but they're people that have been trained for 2 to 3 years in how to do basic essential emergency surgery. And this has become the paradigm, as you see in several countries in Africa. And it works there. It may not work in the Caribbean, it may not work in Asia, but it works there. So you have to be able to go with things that you think are going to work and provide local solutions. Just to kind of start to wrap up, I hope this has kind of stimulated your thinking in terms of how do you deal with public health problems in kind of non-traditional ways that aren't typical for public health policy. The other thing the other thing we need to keep in the back of our minds, and I think probably the most important thing when it comes to surgery in this field, is to understand that there needs to be a shift in the paradigm of thinking of surgical problems. And there needs to be a shift because there's becoming a shift in disease processes in the world. We're moving away from communicable diseases to more non-communicable diseases, okay? So we really have to have infrastructure that supports an entire spectrum of disease processes. So in terms of surgery, we need to stop thinking vertically. We need to stop meeting acute needs with things like Médecins Sans Frontières, which is Doctors Without Borders, or things like Operation Smile, which you guys have all heard of. And they do nice things. They go in, they drop in, they do a lot of good work. However, that's not getting at the problem I got to on the first slide. Okay? We need to start thinking about surgery horizontally across disease processes and across interventions. Okay? We need to integrate with the public sector. Okay? That's the only way to make sure it's sustainable. And we also need to focus on training. Okay? So we need to support institutions like this, which is the Central and South African College of Surgeons. And also non-governmental organizations like this, Partners in Health, which partners with public institutions to try and deliver care. So this is my wrap up. I think I do have one more slide. And it's just a little anecdotal story. This is a good friend of mine from Burundi. He's my age. He's a doctor there. And he's a pretty low-key guy, unassuming guy, but brilliant guy. And we were talking, and he was saying what he wants the most in his healthcare facility is an operating room so he can do emergency C-sections. Too many moms are dying. And he's here in the United States getting a PhD in a graduate program in Boston. And, you know, I thought I was gonna inspire him a little bit and say, hey, you know, maybe someday you'll be Minister of Health, you know, in Burundi. He's like, oh, yeah. He's like, no, that's okay. I think I'm going to be president. And I was like, all right. So my point is there is no lack of inspiration. There's no lack of will to do things at a very high level. We just need to partner with the right people. That's the end of my talk.